Muted.
And welcome to today's webinar. We're pleased that you're able to join us in the next of the Rural Healthware series of webinars. Today we'll be presenting on the National Cervical Screening Program, and with us today is Heidi from the Western Australian Cervical Cancer Prevention Program. Heidi is a clinical nurse consultant from there, and once she gets started she'll tell us a little bit more about herself. For this webinar, as usual with our webinars, we do have you all muted this afternoon just to minimise any background noise. But we do encourage you to chat with us throughout the webinar. If you do have any questions for Heidi, you can enter them into the chat box, and we'll keep an eye out on them as we go along. Otherwise, we'll encourage you to ask some questions at the end of the webinar too. So without further ado, I will pass you on to Heidi, and she'll get started with the webinar.
Hello, good afternoon, everyone. So my name is Heidi Pavicic. As Beth mentioned, I'm a clinical nurse consultant with the WA Cervical Cancer Prevention Program. And just to tell you a little bit about myself, my background, I've been a nurse now for 17 years, which has largely included obstetrical and gynecological nursing in Canada. And I've been in Australia now for the past 5 years. So my practice as a nurse has also included nurse practitioner practice in Canada, where I specialized in obstetrical and gynecological practice for my patients. So to get started, just before we get started, just to take a moment to have an acknowledgement of country. So the WACCPP would like to acknowledge the traditional custodians of this land in which the sharing of knowledge takes place. We would also like to acknowledge the elders of the past and those of the present. So to give you a little bit of an overview of what I'll be talking about today, I'll be talking, of course, about cervical cancer, and you can't talk about cervical cancer without talking about HPV. We'll be talking about how we prevent cervical cancer, and of course, probably why everyone's here today is to learn a little bit about the renewal of the National Cervical Screening Program. So I will go into the evidence behind the changes that are going to be coming into play on 1 December of this year, and as well how we can communicate those changes to women and what resources are available to support women and healthcare providers. So cervical cancer, it's largely preventable and curable if detected early. Most cases can be prevented. So within Australia, 4 out of 5 women who develop cervical cancer have either never screened or do not screen regularly. And as you can see in Australia, in comparison to worldwide, Australia, cervical cancer is the 14th most common cancer in women versus worldwide, it's the 4th most common cancer in women. And this is, of course, related to many other countries in the world that do not have an organized screening program or appropriate follow-up to initiate treatment. That cervical cancer is actually quite common in those countries. So although cervical cancer is largely preventable through cervical screening, still in 2014 in Western Australia, we had 113 cases of cervical cancer and 24 deaths from cervical cancer, which of course is quite sad, being that it is a largely preventable disease. So the symptoms of cervical cancer, usually there aren't any symptoms. Most women are asymptomatic. So if a woman does present with symptoms and it is cervical cancer, usually this is at the later stage. Some of these symptoms can include abnormal vaginal discharge, postcoital bleeding or spotting, having any bleeding or spotting in between periods, or the woman may present with heavy periods or pain during intercourse. So as these are red flags for cervical cancer, all women who present with any of these symptoms require investigation. And this is regardless of the date or the result of their last pap smear. So for example, if someone had a negative pap smear just 1 year prior and now presents with postcoital bleeding or spotting, one of the investigations that should be conducted is a pap smear. So the different types of cervical cancer. So the most common is squamous cell carcinoma. And squamous cell carcinoma develops in the ectocervix, which is the outer cervix. So this is the area that's quite easy to sample and is well picked up on pap smear. So the pap smear has been highly successful in reducing the rates of squamous cell carcinoma. Then you have adenocarcinoma, which is in the glandular cells. So these are in the cells of the endocervix, the inner part of the cervix. And because it's further up in the cervical canal, these cancers are harder to detect, and they're not well detected on the pap smear. So screening with the pap smear has, for over 25 years, has really not made much of an impact on adenocarcinoma. And this is in comparison to squamous cell carcinoma, where screening with the pap smear is highly effective. And then, of course, you have some other types of cervical cancer, which can include mixed adenosquamous carcinoma, so sort of both of them together, small cell carcinoma, as well as cervical sarcoma. So risk factors for cervical cancer, the main one we now know is persistent infection with the human papillomavirus. And because HPV is sexually transmitted, a risk factor, of course, is having multiple sexual partners, or the woman might only have one partner, but her partner may have many different partners. That also puts her at risk. Young age at sexual debut, and again, that's just related to an increased time interval that the woman could have acquired the HPV. Cigarette smoking is a risk factor, as well as being immunocompromised. Because HPV is a virus, if there's any issues at all with the body's immune system functioning, such as women who are HIV positive or being treated for autoimmune disease, these women are less likely to be able to clear the virus, and therefore they're more likely that the HPV persists in these women and leads to changes in the cells of the cervix and potentially cervical cancer. So what is HPV? It's a double-stranded DNA virus. It infects both cutaneous and mucosal epithelial tissues. And as I mentioned previously, it's a really easily transmitted it's easily transmissible, sexually transmitted infection. And that being said, penetrative intercourse is not required for transmission. So this is really important when having discussions with women and about whether or not they've been sexually active, because often women assume that if you're asking them if they're sexually active, they'll think if I have not had penetrative intercourse, then no, I'm not. But it's really any type of sexual activity, HPV can be transmitted. So although condom, and we want to promote condom use, particularly in certain populations, in terms of HPV, condoms offer minimal protection. Essentially, the person would have to be wearing a condom from head to toe to be protected in regards to HPV. So because it's so easily transmitted, it is essentially expected in a sexually active person. And it's really important that when we communicate about HPV to women and to men as well, that we really strive to normalize this. Because it is an STI, we want to make sure that there's no stigma attached to this. So a person who has not had HPV is almost the odd one out. It does infect 4 out of 5 of sexually active people at some point in their lives. And because it's sexually transmitted, it is most common in younger persons, so young men and women, late teens, early 20s. And most cases are subclinical. So again, most people are going to say, what do you mean I've had HPV? Well, it's probably because you've had it, the body's taken care of it, gotten rid of the virus on its own, and the individual is not even aware that it was there in the first place. So as I've said, in terms of the body can clear the virus, most people do successfully clear the virus within about 2 years. And again, I mentioned previously, the clearance of HPV is influenced by how well the immune system is functioning, cigarette smoking, and in women, exogenous hormone use. So for example, women using the oral contraceptive pill for greater than 5 years, it affects the body's ability to clear HPV. So in addition to cervical cancer, HPV causes many other cancers as well. So oropharyngeal, anal, and penile cancers as well. So it does affect cancers for both men and women. And 40 types of HPV specifically affect the genital tract, and these include both low risk and high risk types. And I will touch on that a little bit. So their low risk types are generally non-oncogenic. And I say generally because most of the time they do not cause cancer. They do, however, cause genital warts. And about 90% of genital warts are caused by 2 low-risk types of HPV, those being type 6 and type 11. Also, low-risk HPV can cause some changes in the cells of the cervix, which when you get the pap smear report back, this would be low-grade, a low-grade report on the pap smear. Now, when a woman has a low-grade report on a pap smear, you're aware that HPV is there, but not aware if it's a low-risk type or a high-risk type. So high-risk HPV does have oncogenic potential, and I stress the word potential because the majority of people will clear high-risk HPV. Type 16 and 18 specifically do cause about 70% of our cases of cervical cancer. And the longer the high-risk type sticks around, the less likely it is the body will take care of it. And still, that being said, most will resolve. And they're now finding that if you've had one type of high risk or HPV in general, one type of HPV, and if the body has cleared it on its own, that you might have some protection to that type in the future. So, for example, if someone is sexually active at, say, for example, they acquire HPV type 16 when they're 18 years of age, and the body clears the virus on its own, and then again when they're 25 they come into contact again with that same type of HPV, that they won't get it, that there will be some level of immunity in the future against that particular type. So this is just to show you how HPV leads to cervical abnormalities and can progress to cervical cancer. So on the far left, you have a nice, normal, healthy cervix, and then you have it progressing over to HPV and the person getting HPV. And from there, that can change and progress to some high-grade abnormalities on the pap smear. So this is, of course, the stage when, of course, we're referring women on for colposcopy to confirm that this is a high-grade change and potentially offering the woman treatment. However, at this stage, the body can still clear the HPV and the cells can regress back to normal. Now, in a small number of cases, of course, this will progress and it will progress on to cervical cancer. The time frame for this, we now know, is quite long. So from a person getting HPV to cervical cancer occurring is actually about 10 to 15 years. So it's not something that at all progresses quickly. It's a very, very slow progression, which is why you can see with screening women every 2 years with the pap smear, why we have so effectively reduced the rates of squamous, particularly squamous cell carcinoma within Australia. Now, I just want to point out to you one other thing on this diagram before we progress. And you see on the bottom where you have the caveat for a latent infection. And this is where a person can get HPV. For example, if a person can get HPV type 16 when they're 18 years of age and the virus goes to sleep, so the pap smears might be normal, and then the woman, when she's in her 40s, for whatever reason, the virus reawakens and then starts to cause changes in the cells of the cervix. So this is why it's so important that women who continue to screen, even if they're no longer sexually active, and even if they're in a monogamous relationship. So very important when having discussions with women about this. So how do we stop HPV and cervical cancer? Well, in Australia, we have two ways. We have vaccination and we have cervical screening. So prevention through vaccination. So everyone's well aware of our National HPV Vaccination Program that in 2007 kicked off for the girls, and in 2012 was extended to the boys. And of course, the reason for extending the vaccine program to the boys was that by protecting the boys, you're also protecting the girls. But also, really important that the boys are vaccinated as well too, because as I mentioned previously, high-risk HPV causes many other cancers other than just cervical cancer, that it also causes penile cancers, anal cancers, as well as squamous cell carcinoma of the head and neck. So very important that both boys and girls are included within this vaccination program. So we do have two types of vaccines available in Australia. Both they're Gardasil and Cervarix. They're both given quite similarly. Their effectiveness and side effects and whatnot are pretty much the same. But the main difference is that the types of HPV that they protect against. So both types protect against type 16 and 18, which of course cause about 70% of cervical cancer cases. But Gardasil, which is the vaccine type that is given in Australia, also protects against type 6 and 11, which, remember, it's type 6 and 11 that cause the majority of cases of genital warts. So this is just to show to you how Australia is faring in regards to our young girls having completed all 3 doses of the vaccine. So within Western Australia, we're sitting about 75%, so that's quite good actually. And that being said, this is for 3-dose vaccination coverage. They're actually now finding that even someone having just 2 doses is pretty much, it's pretty much on par actually to having the 3rd dose. Now that being said, we still want to encourage our young people to have all 3 doses, but I think it's very exciting that now that that we now know that 2 doses actually gives good protection. So this is just to show you the impact of the vaccine in Australia. So already we're seeing fantastic results. So there's already been a decline in HPV infections. There's been a substantial reduction in genital warts. I saw a talk recently by a sexual health physician who said that probably a few years down the road, genital warts are going to be almost obsolete. That, you know, it'll be one of those cases that someone comes in and there's a patient with genital warts in the clinic, and it's, oh my goodness, everyone, we got to come see this. There's actually a genital wart. Haven't seen this in ages. So fantastic. Also, they've now seen that there is a reduction in confirmed high-grade abnormalities in young women who've been vaccinated. And as time has elapsed, we're even now seeing this is extended into the age cohort of women aged 30 to 34 years. So the vaccine already has been very, very effective within Australia. So is it the cure? No, unfortunately not, because remember, the vaccine only protects against 2 types of HPV that cause 70% of cervical cancers. So even if women have been vaccinated, they're still at risk of cervical cancer from those remaining types of HPV. So vaccinated women still need to continue to screen the same as unvaccinated women. And very important that we continue to promote screening to this cohort. We are well aware now, and this has actually been proven by data through the Victorian Cytology Register, that vaccinated women are screening less often than their unvaccinated counterparts. So there is that misconception out there amongst some vaccinated women that I've been vaccinated, therefore I don't need to screen. So very important that we promote that message to all women, that all women need to screen. And although HPV vaccination has already had fantastic results within Australia, the full effects of the vaccine on cervical cancer rates will not be evident for a while. And that makes sense, because think about how long it takes from getting HPV to developing cervical cancer. So I'm sure, though, that we will in the future see some fantastic outcomes. So although HPV vaccination is a great initiative to prevent cervical cancer, it has to be delivered in collaboration with cervical screening. So population-based cervical screening. So having an organized population-based approach to cervical screening is pivotal to reducing cervical cancer incidence and mortality. And this is clearly demonstrated through Australia's National Cervical Screening Program, which since it started in 1991, Australia has seen a decline in the incidence and mortality from cervical cancer by more than half. So a very highly successful program. So everyone is well aware of our current program. So yes, it's 2-yearly screening for all women who have a cervix with the pap smear. And women, for right now, women commence screening between the ages of 18 to 20 years or within 1 to 2 years of becoming sexually active. And that's whichever is later. And of course, once a woman turns 70, as long as she's had 2 negative pap smears in the previous 5 years, she can discontinue screening. So our current program has been around since 1991. A lot has changed since 1991. We now know that HPV is required as that necessary first step to develop cervical cancer. There's a lot of international and local evidence on cervical cancer prevention. In different countries, and I'll have a slide on this a little bit later on, different countries are doing things differently. And when I say different, I mean less intensive than Australia's program and having similar outcomes. We also have new technologies. We can now test for HPV. We can now offer women liquid-based cytology screening. And as well, of course, in 2007, there was the introduction of our National HPV Vaccination Program. So this changing environment led a need to review the current NCSP in a renewal. So the objectives of the renewal were to assess the evidence for the effectiveness of screening tests and pathways, the screening interval, when women should start screening and when women should stop screening. And of course, this has to be cost effective and it has to be acceptable to women. And I see that there's a question from someone who's participating asking, is it worth mature-aged women also being vaccinated? And that's a fantastic question. So the benefits of the vaccine, it's most beneficial if it's given prior to someone becoming sexually active. Now, the question often comes up about mature-age women because often maybe, for example, they've been married and in a monogamous relationship for a set period of time, and then maybe they're widowed or they're divorced, and then they become sexually active in a new relationship. So there might be some benefit to that woman being vaccinated, but we're not sure as to how great that benefit is because, of course, we don't know what types of HPV that woman has been in contact with in the past. So we might be vaccinating her against the 4 types of HPV, but perhaps she's already come in contact with those types and maybe the body's cleared those types of the virus on their own. So when it comes to older women receiving the vaccine, it really depends on the individual woman. So it's really important to sit down and have a discussion with that woman about the vaccine and the risks and the benefits. And of course, one of those factors for women often is the cost, because of course, if it's not for older women, it wouldn't be covered in the National HPV Vaccination Program, so the women would have to pay out of pocket for the vaccine. And for the 3 doses of the vaccine, it's about $450, and plus on top of that, of course, there's the consultation fee. So I hope that helps answer your question. But yeah, it's really important just to sit down and have that discussion with the woman, just to determine the risks and the benefits. So going back, sorry, to the renewal of the objectives. So we're going to touch on some of the evidence that was found in this. It was an intensive review that commenced in November 2011, and the recommendations were accepted by the Medical Services Advisory Commission in April 2014. So it was a very intensive review. So what they found was they looked at the different screening tests available, and they found that screening women with an HPV test actually provided 60 to 70% greater protection against invasive cervical carcinomas than screening with cytology. And there was one study, actually, it was done in India. It was massive. It included about 140,000 women across 52 villages. And they actually showed in this study that a woman having one HPV test in her lifetime actually decreased her chances of dying from cervical cancer. And that same result was not found with the pap smear. So I think that that's quite strong. Because the HPV test is a more effective test, because again, you're finding the virus that's going to cause those changes in the cells of the cervix. You're looking for that very first step in the potential development of cervical cancer. Because of that, it can safely be instituted with a 5-yearly screening interval. And actually, a lot of the evidence showed that it could even be safely instituted in a screening interval of 6 or 7 years. Now, this being said, if you were just to test all women for HPV, if you think about how common HPV is, you would be sending a lot of women with a positive HPV result on for colposcopy who maybe didn't need it. So if you do an HPV test and then also do a cytology test, so like the pap smear, you're going to look at the cells of the cervix to determine what effects that HPV virus has had on the cervix thus far, and then from there determining which women would need to go to colposcopy is a positive way and meets a need for a balanced cervical screening program, because of course you have to balance in terms of who you're sending on for additional investigations and treatment in terms of the woman in an emotional sense of having to go on for a colposcopy, and as well as cost to the system, of course. So another key finding of the renewal investigations was in regards to self-collection of an HPV sample. And when I say self-collection, this is a vaginal swab. This is by no means asking women to go and find their own cervix and to do a cervical sample. It's just a vaginal swab for HPV. Is that they found it was a highly useful strategy to improve screening participation in women who are underscreened or never screened. And remember, it's women who are underscreened or never screened who are most likely to develop cervical cancer. So they're our most at-risk population. And there was one study that was done in the Netherlands. It's called the PROTECT study, I believe. And what they did was they invited women who were underscreened or never screened to have a self-collected sample. And based on their study findings, they said that offering self-collection in the Netherlands could improve their screening participation rate by 5%. I mean, that's substantial. Again, that 5% improvement being in women who are most at risk for cervical cancer. So, although it's a fantastic strategy for the underscreened, never screened population, was not found to be cost effective for the whole of population. So another key finding of the renewal was in regards to women less than 25 years of age. So we know that HPV in young people is high. So it's no surprise that it's women less than 25 years of age who have the highest incidence of cervical abnormalities. Now, this being said, they have the highest incidence of cervical abnormalities, but they're the least likely cohort to have cervical cancer. So in regards to their cervical abnormalities, there was a study that found that 10% of these women will have abnormal cytology results, 1.5% are referred to colposcopy, and half of these women are referred on for treatment. And remember, treatment does not come without risk. Treatment can put these women at risk for the potential for future pregnancy harm. So essentially, the investigations into the screening in women less than 25, it was found that the risks of screening clearly outweigh the benefits in this younger age group. And this being said, although we've been screening this age group for over 25 years within Australia, this has not decreased the cervical cancer incidence or mortality in this cohort. And this is just to show you, so this is, it goes back, so pre-implementation of the NCSP, this goes back to 1983, and you can see the impact of where screening was introduced, and particularly you can see the impact as women are over 25. But when you look at those in the 20 to 24 year age group, there really is no change. So this is just to give you an idea of what's going on worldwide in regards to cervical screening. I put Canada up there because I'm a Canadian girl, but that's not the main country I want to draw your attention to. So if you look at some of the other countries, for example, Finland, they only screen women every 5 years. They actually don't start screening until women are 30. However, they have a similar incidence and mortality from cervical cancer as Australia does. So it has been demonstrated that you can have a less intensive program, but it still be highly successful still. So the outcome of the renewal, and of course most of you are probably already aware of this, Australia is going to be moving to screening with a 5-yearly cervical screening test. And what the cervical screening test is looking for, it's looking for HPV, and it's actually partial genotyping. So it's going to tell you if the woman is positive for type 16 or 18, which are the most risky, remember, for cervical cancer development, as well as some other high-risk types of HPV that we know can cause cervical cancer. So if those types of HPV are found, the laboratory then automatically on that same sample will conduct a cytology test, so like the current pap smear. The screening age range is going to change. It's going to increase to 25, but we're going to go a little bit longer. We're going to extend that up to women up to age 74 years. Also, we're going to offer self-collection for a select group of underscreened and never screened women, and I'll touch a little bit on that eligibility criteria in a couple of slides. Now, this being said, this is a population-based screening program. This is what's good for the majority of women the majority of the time. So it's still up to the provider to have a discussion with that individual woman sitting in front of them to determine that this fits. And the majority of the time it will fit. When it doesn't, for example, like women with symptoms, any woman with symptoms, regardless of her age, should be offered a cervical screening test. So what does the renewal mean for women and providers? So the procedure for collecting the sample is still unchanged. The only difference is going to be that the sample medium will be liquid-based cytology, so no more pap smear slides. As I already mentioned, if HPV is found, then the cytology testing will automatically be done. And the total number of lifetime tests for a woman will now only be 9 or 10, in contrast to the previous 26. And as a woman, I say yay to that. Fantastic. But I put in bold the key point is that there's anticipated to have a 30% further reduction in cervical cancer incidence and mortality in Australia. And part of that is related to we're testing for HPV, and HPV can also cause adenocarcinomas. And remember, the current program with pap smears is not as good at detecting those adenocarcinomas, so that's going to be part of that. And I think that's key to these changes. So how should women be transitioned to the Renew program? So most women will be due for their first cervical screening test 2 years after their last negative pap smear. So for example, if a woman has a negative pap smear, so today, March 30th, 2016, or sorry, 2017, I got the year wrong. March 30, 2017, she would be due for her first cervical screening test in March 2019. Women who are undergoing follow-up or treatment, this is outlined in the new guidelines that are now available. So these are the guidelines for the management of screen-detected abnormalities within the Renew program, and those are accessible on Cancer Council Australia's wiki platform at that link. So how are results going to look, and how should women be managed within this new program who do have abnormalities? So it's going to be a traffic-like system. So green for go, yellow for caution, and red for hold up, go straight to colposcopy. And I'll touch on that on this slide, which is quite lengthy, and it's not an easy to digest slide. But if you look over on the far left, you see that's HPV not detected. So those women will then rescreen in 5 years. If you scroll over to the red, for women who have HPV detected type 16 or 18, those women will automatically go to colposcopy regardless of their liquid-based cytology results. Then for those women who have those other types of HPV detected, they're going to be managed according to their cytology results. And that is going to be actually similar to the current program. So if they have a low grade or possible low grade, they'll repeat test in 12 months. And for women who have a possible high grade or high grade abnormality, those women will be sent on for colposcopy. So self-collection, again, this is a vaginal swab for HPV. Women who are going to be eligible for self-collection of an HPV swab are women who, number one, they have to be asymptomatic, they have to be at least 30 years of age or over, and either never screened or underscreened. And the definition of underscreened is two years or more overdue for screening. So during the transition to the Renewed program, this is going to be a woman who's 4 years or more 4 years or more since her last negative pap smear, and post-transition this will be 7 years or longer since her last negative cervical screening test. And another eligibility criteria is that the woman must also decline a provider-collected sample. So remember, the provider-collected sample is sort of the gold standard. It's a better test. So providers should encourage women to have a provider-collected sample, but for those women who still refuse and they're underscreened or never screened, this is another pathway that is available to them. So the National Cancer Screening Register is going to support the Renewed program. So it's going to be a register that supports, in addition to the cervical screening program, also the bowel cancer program. Legislation for the register was passed back in October 2016, and Telstra Health, I'm sure everyone is aware, was awarded this contract. So the NCSR key functions, so similar to the current state and territory-based registers, the NCSR will send women reminders when they're overdue for screening or for follow-up, and as well send providers reminder letters if the woman within their practice, for example, has a high-grade abnormality that was detected and she hasn't gone out for follow-up. That will also, a letter will also be generated. But in addition, what's going to be new with the NCSR is that they're actually going to send women invitations. So when a woman, for example, turns 25, it's going to be happy birthday, come on down and have a cervical screening test. Also, the NCSR is going to be available to healthcare professionals to access women's screening history, and this is forecasted to be that this will be managed through either their practice management software or via a web portal. So what's happening until 1 December? Well, until 1 December, it is business as usual. It's very important that women who are due for screening or due for any follow-up continue to attend when due. We are aware that some women maybe have been delaying screening up until, which initially was going to be 1 May, the implementation date. It's very important that women don't delay, and they should be encouraged to continue screening. So there's going to be the MBS items, there's going to be a couple of revisions that are going to occur. So the MBS items for the pap smear are still going to be available up until 1 December. And also on 1 May, a new MBS item is going to be added for liquid-based cytology samples. And this has been added just to support the cytology workforce during the transition. The new MBS items for the cervical screening test will be added on 1 December, and also on 1 December, remember the MBS items for the pap smear will no longer be available. So this is communicating the changes to women. Just some key points for you. These are some questions that women often ask. Women are often unaware of what HPV is, and I've even heard of people confusing HPV with HIV. So very important that we're clear in our discussions to women about HPV. So it's very important that women are aware that HPV is a very common virus that most people have had in their lifetime, that it's spread through any sexual contact. And I used to say to I had often young adolescent patients in my nurse practitioner practice in Canada, and I'd say to them, ladies, any pants off fooling around, you could have gotten it, and then you need screening once that's occurred. Also to let people know that most people will clear the virus within about 2 years. And if the body doesn't clear the virus, yes, this may lead to cervical cancer, but again, this is uncommon. Most women will clear the virus, but this takes a long time. It usually takes up to 10 to 15 years. Women will also often ask, what if I've had the vaccine? I don't need to screen. And women will often say, I've had that cervical cancer vaccine. I don't need pap smears anymore. So really important that these women are made aware that the HPV vaccine protects against 2 types of HPV that cause many cases of cervical cancer, but does not protect against all types. So vaccinated women still need to screen the same as unvaccinated women. Women might ask why the screening interval is changing. It's a bit of a jump to go from a 2-yearly screening interval to a 5-yearly screening interval, and just to reassure women about the evidence behind this change. And the evidence being that screening for HPV every 5 years is actually more effective than and just as safe as screening with the PAP every 2 years. And that although the current pap smear detects abnormal cell changes, this new cervical screening test will detect the infection that causes the abnormal cell changes prior to the development of the cancer. And from there, the woman might say, well, what is this new test, this new cervical screening test? And it's really 2 tests in 1. So first, they're going to test for HPV, and then if that's positive, then the cells of the cervix will be tested for any abnormalities, like the current pap smear. From the woman's perspective, the procedure is exactly the same. I appreciate that there is some misconception out there about that all women are going to be eligible for self-collection or it's going to be a different procedure. No, from the woman's perspective, the procedure is exactly the same. And actually from a provider's perspective, it is too. The only difference is you're not smearing a slide, you're using a liquid-based cytology sample instead. So how about women less than 25 years? Why are they going to no longer be screened? Again, just to let women know that cervical cancer in women under the age of 25 is rare. And investigating and treating common cervical abnormalities in young women that usually go away by themselves can increase the risk of pregnancy complications later in life. Also, the vaccine has been already shown to reduce cervical abnormalities among young vaccinated women. And although we've been screening women, so this is what we've been doing, and this is why this is going to be a concern for some people, because this is a change. We've been doing this for 25 years. And you're right, we have been doing it for 25 years. But this has not changed the number of cases of cervical cancer or deaths from cervical cancer in this age group. And again, we want to let women know that if they have symptoms, they need to see their healthcare provider immediately. And I see that someone has a question. Oh, the question is in regards to the press fanfare about losing our free access to cervical screening. What is that all about? And I think that just refers to concerns about the MBS item numbers and the costings, the rebates for the pap smear. And the rebates for the pap smear are actually going up as well on 1 May, and I can't recall off the top of my head. I think it's going up to $29, and the liquid-based cytology is going up to $36. So there should ultimately we don't want women to incur an extra fee for this, and they shouldn't. A woman will incur a fee if she has a liquid-based cytology test prior to 1 May, and a woman will incur a fee for the cervical screening test if she has that prior to 1 December. But otherwise, it should be Medicare rebatable, and those increases with the Medicare rebates should help to support women to be able to have a test and not to incur an out-of-pocket expense. I hope that helps to answer that question. So to continue on with communicating the changes to women, so will all women be able to self-collect? Again, this is a big one. Lots of women are thinking, oh, like, for sure, I don't want the pap smear, I just want to do it myself. But again, it's only available for those women who are 30 years of age or older and who've never screened or overdue for screening. It's not as effective as a healthcare provider collected sample. We really want to encourage women to continue to have that provider collected sample, and also to let women know that even if she has the self-collected sample, that again, if it's positive, she needs to come back for a second visit for a cervical sample to be collected. And ultimately, it's not cost-effective for the whole of the population. But again, it's important to increase screening for underscreened and never screened women. Oh, I see another great question coming up. I'll just pause for a second here on the presentation. So the question is about what about girls who have been sexually abused as children? How will the HPV protect them, and when should they be screened? So that's actually covered within the new guidelines, and I'm really happy it is, because I think previously that was probably something that was it wasn't something that was talked about or addressed, that providers had any guidelines in that regard. So within the new guidelines, there is a section on for women who have commenced sexual activity, whether or not it's consensual or not, prior to being vaccinated. And for those cases, providers could offer a woman one cervical screening test between the ages of 20 to 24 years. So those women, at the discretion of the provider, and ideally that's the provider having that discussion with the woman, that she could be offered one screening test when she turns 20, for example, if that's appropriate for her. Hope that helps answer that question. So just to let you know about some resources that are available. So resources for women, there's going to be a range of national and state online and printed materials that are being developed. And these are seeking really to inform women about the changes. Why are these changes happening? What is the new cervical screening test? And they're going to be available over this calendar year. So this is just to let you know about a flip chart that's currently in development that our program has developed, and it's been developed in collaboration with our programs in Breast Screen. We have a joint Aboriginal Women's Reference Group, and this includes representation from Aboriginal women across WA, and the group seeks to provide us support and input on our resources and initiatives to make sure that they are culturally appropriate for Aboriginal women. So this is a flip chart resource that we're developing to support healthcare providers to have discussions with Aboriginal women about cervical cancer prevention. And we're going to be doing a pilot testing of the first draft of the flip chart in April, and a roadshow to kick off and promote the flip chart is being planned for mid to late 2017. And the renewal implementation, along with that, will coincide the flip chart's availability. So other resources for healthcare providers, as I already mentioned, the guidelines are now available on Cancer Council's wiki platform. Now, these guidelines are available currently just to help healthcare professionals to prepare for transitioning to the renewed program. They're for reference purposes only until the renewed program is implemented. So this is just to let providers know that we're not expecting them to implement these guidelines currently. The 2005 guidelines should still be utilized up until the 30th of November, and then these new guidelines will kick in from then on. Also, the WA Primary Health Alliance is developing a cervical screening health pathway, and this health pathway is going to be available across Australia, and that's going to be available closer to the implementation date. Other resources for healthcare providers, Cancer Council Australia is also developing a toolkit for engaging with underscreened and never screened women, and this is going to be available prior to the renewal implementation. There's also going to be a whole suite of resources to support providers in implementing the renewed program that will be progressively available throughout 2017. Education for healthcare providers. So Sexual Health Quarters, which was formerly Family Planning WA, has an online education for WA providers, and it does include information about the the renewed program and the evidence behind the changes, and that's accessible at that link. Also, NPS Medicine-wise has developed online education modules. I think there's about 6 different modules. They're quite comprehensive. They're fantastic, and those will be accessible on their website. I don't have a date yet for when those will be publicly released, but I would assume that that would be prior to implementation. Also, to support the providers in their understanding of how to implement the clinical management guidelines, they have developed some online education, and these are like different case studies that you can go on and use those to sort of practice your knowledge around the renewed guidelines, and those are accessible at that link. I see another question, and it's in regards to lesbian women. So lesbian women should screen the same regardless. Screening is for all women, regardless of their sexual orientation. Very important, because remember, HPV is transmitted via skin-to-skin contact. Its penetrative intercourse is not required for its transmission, so that they're screened the same as the entire population. There's no special stipulations. So renewal communications. So what is our program doing in terms of renewal communications? We have a whole range of strategies planned, and this is to communicate the changes both to women and to healthcare. Newsletters and e-bulletins, presentation and information stalls, as well. We'll be doing a mail out to healthcare providers. We're also going to have available on our website information about upcoming education events and opportunities, presentation recordings, downloadable resources, FAQ sheets, and as well presentation templates. So if providers, for example, want to deliver a presentation to colleagues, they could use the presentation template to do so. We also hope to have a presentation template available for healthcare professionals who want to do a presentation to women to raise women's awareness of these changes. And those will be available over the coming months. Additionally, we're going to be having a renewal campaign, and this is going to align with the Commonwealth's renewal campaign. And again, it's going to include a range of strategies to increase awareness of the renewed NCSP. And it will include a stakeholder campaign kit as well, so that you're supported in terms of delivering the messages to women or other providers within your region. And if you want to stay up to date on information about the renewal being implemented within WA, you can visit our website, or as well, we have a newsletter, and we provide regular updates to our stakeholders who are on our distribution list. So feel free to email us, and we'll add you to the list for that. Other renewal information, if you want to know what's going on at a Commonwealth level, you can visit their website. Also, the Commonwealth has a newsletter. It's called the Partner Reference Group newsletter that's sent out. And if you email the Cervical Renewal team, they'll set you up on their distribution list. And if anyone's very interested in reading the MSAC recommendations, it's several hundreds of pages. Feel free. You can access it at that website there. Were there any other questions? We do have a little bit of time.
Thank you, Heidi, for that really informative session. Heidi and I are going to stay online for another 5 minutes or so, we will take any further questions. In fact, I can just see another question that's come through about somebody who's missed the first part of the presentation. So we have recorded today's webinar, so if you want to come back to it as a refresher, or if you want to pass it on to any of your colleagues, we'll be uploading it to the Rural Health West website shortly, so that will be available for everybody. So yes, if you'd like to sign off, you're more than welcome to. We have just finished a few minutes earlier, but if you do want to stay on and send through any other questions. And also just to remind everybody that our next webinar will be taking place on the 6th of April, and that's going to be the QI and CPD requirements for GPs. So we invite you all to register to that one too. I'm going to pass back over to Heidi at the moment because I can see a couple of other questions coming through, so I'll get her to respond to them.
Oh, one of the questions was in regards to the PIP payment, and I'm assuming that this is related to the PIP incentives for cervical screening. And I have to say I'm not quite 100% sure whether or not that will continue post. I might have to get back to you on that one, but I wasn't sure if it was going to continue or not. Another question. Oh, the swab for self-collection. I actually don't think that has been determined yet. We haven't heard yet what specific swab that's going to be used. And again, it might vary a bit depending on the laboratory. But it was just like there's different ways to do the self-collection sample. But the one that we used in Australia, it's just like a cotton tip swab. And I think that was it for questions, unless anyone else wants to shoot through any more. Well, I can see that looks like it's it for questions for now. If anyone does think of any questions after we close off for today or over the coming months, feel free to give us a ring, to flick me or flick the program an email, and we're more than happy to follow up on that. So thank you all so much for your time today, and hope you have a great day.